I am sorry, but I will stay with you some more. And today we will talk about flow diverter technologies. This is the usual conflicts. Flow diverters. So we started with these two different flow diverters in 2008, at the end of 2008 and the beginning of 2009. So it's a long time ago. And the pipeline at the time was by Chestnut Medical, which then became EV3, which then became Covidian, and which finally today is Medtronic. So each company was buying the previous company, and they made a lot of money. Then we had other flow diverters coming, the FRED. This is a list in the chronological order, the P64, the Surpass, and the Derivo. And then each company made changes, and we had the Shield, the Silk Vista, the Fred Junior, the P48, the Surpass Evolve, and the Bravo from Cerenovus. So this is the pipeline. We started in October 2008, and it was the very first flow diverter that we used. Immediately after that, we started with the Silk, and in the first 2 years, we did more or less half and half pipelines and Silk. Then the streamlined Surpass came, and we used it very little because it was a very difficult device, very stiff and hard. Then the FRED by Microvention in February 2013, P64 by Phoenix, October 2013, the Derivo, December 2013 by Acandis, and then more recently the Silk Vista Baby, which is a smaller flow diverter that goes in a smaller catheter, the Bravo by Cerenovus, which is not yet in the market, and the Surpass Evolve in June 2019. So why flow diverters? Where do they come from? They come from ideas which are very, very far away in time, because we understood that recanalizations were very frequent when we had to place something inside an aneurysm, and it would be better to fix the vessel rather than fill the hole, because the disease is in the vessel, it's not the aneurysm. The aneurysm is just a consequence of a diseased vessel. And so we were looking at dissecting aneurysm in the neck, and we were treating those with the carotid stents. And it worked very well. And we said we should do that also inside the head. And the stents we had at the time are coronary stents, were coronary stents. And this was one of the first cases where we wanted to do that. It's a 42-year-old lady who had a subarachnoid hemorrhage due to this dissecting aneurysm of the vertebral artery. We could not occlude the vertebral artery because the other vertebral artery was not good enough. And in 1999, we used a coronary stent, which was a sequence Nicomed stent. You can see it here. No, you cannot? Okay. I think it's... Well, okay, doesn't work very well. Maybe you can see the stent there, opened at the level of the neck of the aneurysm, and this was before, and this is the 1-year follow-up. Not perfect, but certainly we had no rebleeding. So it was a first idea we should fix the vessel and not the aneurysm. So in the early year 2000s, I went around in meetings and saying, well, we need stents for the treatment of aneurysm. And what do we need? We need an intravascular device which is capable of excluding an aneurysm from the arterial circulation. It would be better if this device could stay in the vessel without entering the aneurysm, so we don't risk the rupture of the aneurysm because we stay in the vessel. The whole diseased part of the vessel wall were repaired, and all the normal branches or perforators were spared. So these were the desires we had. It didn't exist anything like this. So we would be better because a safe, non-traumatic procedure with everything under control, a self-expandable stent, which was not available at the time, low friction, smooth progression, retrievable, resheathable, well fixed, no movements, with a safety wire inside. This is what happened. Then these were our desires, and the flow diverters responded to these desires. But we had another possibility at the time, which were the stent grafts, the so-called covered stents. This was and they were coronary, of course, current stents. This was the most used one, the Geomed Abbott stent, but we had also this other covered stent graft, the Cardiovasc, which probably stayed maybe a couple of years, 3 years, which was a little bit less stiff. And in 2007, I presented our experience with covered stents in intracranial arteries. We had 30 patients, and the very first one was fantastic. It was this man, 29-year-old, with a paresis of the left sixth cranial nerve. You can see the horrible aneurysm of the petrous carotid. Again, we could not occlude the carotid. We went there with a normal 6 French catheter. We crossed the aneurysm, and we deployed covered stents. And immediately after the deployment, we just made an angiography, a run. We were holding our breath and saying, what it will look like now? And it looked like this. So this is wonderful. This is what we want, something that immediately takes away an aneurysm. We were very happy, and you can see that it stayed for years, not only, but interestingly, the bone just recreated itself in the region of the aneurysm here. So it means that it's completely cured. So my conclusion in 2007 were that covered stents are a very effective device, but the interventions are technically very challenging because they were very stiff. You had to push this device in a very difficult situation. And so we certainly need something for neurovascular. Why do we need covered stents? Because there are theoretical advantages. There is no need to enter the aneurysm, no need to fill the aneurysm, which can therefore deflate. It's a reconstruction of an arterial channel. It's the cure of the disease of the arterial wall. It's the immediate and persistent cure, so it's cured forever. This I was saying in 2007, and also that it saves the cost of many coils. And again, it's exactly what flow diverters do. So the desire to have flow diverters was strong. We wanted something like that. It had to be the solution. And so, finally, flow diverters appeared. Thanks to this man, Aaron Beretz, in around 2006, he already gave me these pictures that were the first images in an animal for the first flow diverters, where he showed that the aneurysm would just go away, and but the arteries coming off, the branches were staying open. So the aneurysm goes away, but the branches stays. This is what we want. Much better than covered stents, where all the branches would, of course, also disappear. And the first case we did, it was the 2 October 2008. This was the aneurysm. And this is already the follow-up. We placed a pipeline. And the follow-up was this. So this was, as I told you, a wow, which was the first of a long series of wow, because we had so wonderful results. So it's the second revolution in aneurysm treatment. The first one was coils. And we can now treat in a simple way aneurysms that before were treatable only incompletely, if at all. Maybe they were not treatable at all. But if they were treatable, they were only incompletely. Now you have flow diverters in smaller catheters. The Fred Jr. goes in a 21 catheter, Silk Vista Baby and P48 in 17 catheters. The same that you use for coils. In waiting line, we are waiting for the Cardiatis flow modulator. There's a completely different technology with different layers. It's not just one layer. I don't know where they are with it. Some people have tried the very first, I think Pedro Lilik in South America has done a few cases with this, but it's not yet available for us. Then there is the problem of the dual antiplatelet therapy. So now they are working on dual antiplatelet therapy, and one solution or possible solution comes with the shield technology of pipeline flex. As you see, there are question marks there because we are not sure that they work. But there is, an effort. All the companies are working in order to have the possibility to use flow diverters with less and less dual antiplatelet treatment. Why? Because the dual antiplatelet treatment is risky. We have complications due to these drugs. There are differences between the current flow diverters. One of the differences is in the metal which is used. Some are made with chrome cobalt, other are made with nitinol. Both you add platinum to have radiopacity. Then you may have a difference in the number of filaments. Initially, the Silk and the Pipeline, they both had 48 filaments, and they still do have 48 filaments. But then the P64 came with 64, the Fred Jr. had 32, and with the streamlines, the Surpass, Evolve, and Bravo, you may have different 48, 62, 96, so a lot of different numbers. We think 48 is good anyway, so you don't really have to change. Another important feature which differentiates the different flow diverters is the angle. What do I mean by angle? This is the angle of the, you will see, of the filament. which is important for the opening and the foreshortening of the flow diverter. If you look at the silk, the angle is this. If you look at the thread, the angle is this. If you look at the derivative, the angle is this. If you look at the P64, the image is not very good, but the angle is more or less this. So there is a difference in the angles of the filaments compared to the horizontal line. And the steeper is the angle, the more the flow diverter wants to open. But the more it opens, the more it shortens. So remember, with the P64 and the derivo thread, the flow diverter may shorten very much if it's opening very much. So the more, the sizing is important, because if you take an undersize, meaning that the stent is in a large vessel, it will shorten very much because it opens very much, especially the P64, the derivo. And if you take an oversized stent, meaning in a small artery, then it will stay longer. This is very important. You can play with the size of the flow diverter if you want it shorter or longer. And usually, if it's short, all the struts will close more. So if you have perforators, it is better to oversize the stent, meaning in a 3 millimeter artery, use a 4 millimeter stent. It will stay more longer, but the struts will be more open. So in the middle cerebral artery with all perforators, in the basilar artery with all the perforators, it is better to oversize the stent, in my experience. But there is a difference between the different flow diverters available today. Some have a distal wire tip, some don't. Radiopacity and radiopaque markers differ. Silk are softer, streamline are more rigid, especially the old one. PIC 64 and streamline have more filaments. Silk and Fred Jr. can go through a 21 catheter. Streamline is a complex over-the-wire system. Silk, PIC 64 and Fred will shorten more, so you have differences, yes. But these are technical things. The late ones can go through a 17 catheter. But watch out, one very important difference is in the thread, where you have these flare ends. The light is gone. Eh? No more light. Well, not visible. It goes away, but anyway. So they have these flare ends here. In this drawing, you can see the flare ends there. And if you put the catheter inside, if you want to re-enter such a catheter, you may, and you usually do, go from outside to inside. And if you want to place a second flow diverter, you will be inside one of those triangles, and it will not open. It has happened to people. So you re-enter with a catheter, the flow diverter, but you pass through the wrong way. So be careful about that. But the real point that is needed to know if there is a difference in safety and efficacy, because that's a real point. We want to know if the patients are okay at 6 months and for the rest of their life. And I think that there are no major differences in this case. So there are technical differences, but whatever you use, finally, safety and efficacy are very similar. So you may have a preference, like everybody. Some people like Mercedes, other like BMW, other like Ferrari. Nobody like Fiat, but anyway. So it's a matter of preference, taste. Even in our group, yes, there are some people who prefer one, some other people who prefer a different one. There are cases where you have a failure of the treatment, and why it doesn't work. There are factors which influence persistent aneurysm filling. And usually one is timing, which means that you just have to wait. If you do a control too early, the aneurysm is still open. You wait, maybe it's still open, but slowly it will go away. That's why we don't do a follow-up at 1 or 3 months, but we wait at least 6 months. There is no interest in doing a follow-up at 3 months. But another cause of mal-deployment is, of course, unsuccessful treatment is mal-deployment. And that could be due to stent stenosis, bad wall apposition, neck not covered. Another one could be incorrect sizing, too big, too short, too small, too large. Another possibility is an unwanted diversion of flows. And as I've already told you, the problem of the communicating arteries, but we will go again through that. And then, of course, drugs. So you could have a persistent aneurysm. It doesn't go away because you continue to give anti-something drugs, antiplatelets, anticoagulants. So it's better at some point to stop all the drugs. Just an example of why you should wait to have results. This is an aneurysm, strange, at the level of a fenestration of the vertebrobasilar junction. You see the aneurysm. More or less, this is how it's made. So the aneurysm is there, and the neck is here, and then there is a fenestration. And the other vertebral artery is entering here. We place the flow diverter in, of course, the vertebrobasilar artery. Anyway. And at 3 months, it looked, oh, not bad. It's working. But 1 year later, it was like this. This is a horrible result. It's a complete delusion. What should we do? Wait. Now, this was how it went. So it's not a good progression. Is it a complete failure? We wait 1 more year, and this was the final. Oh, thank you. This was the final result at 30 months. So as you can see, it has completely rearranged the flows. Does it work? Thank you. You see now, that fenestration, which was before coming from down here, it came from another side. And here is the progression of the evolution at 3 months, 15 months, 30 months. So the flow diverters act over things, but it needs time. So just wait. Most of the time, you will have the results you like, or at least it works. Problem is mal-deployment. So if it's not correctly placed, it doesn't work. What does it mean correctly placed? it means that it has to be very well opposed to the wall of the artery. All over the artery, well on the wall. If there is any point where it's not really well opened, it will not work. And the number one situation where this can happen is when there is already a stent inside the artery. So to treat an aneurysm which already has been treated with stent and coil, usually you have to be careful. It might not work well. Why? Because the flow diverter cannot go on the wall of the artery because there is already another stent. This is an example of a man with a posterior communicating artery aneurysm, one of those where we don't like it. And in a different institution, it was placed a solitaire stent and coils. Of course, the coils were in the correct place at the beginning. This is already a recanalization after some time. And it comes to us, and we say, okay, we place a flow diverter. And we did place a flow diverter, as most people would do. It looks not bad, but if you look carefully, I hope I can, well, this is the flow diverter, but this is a solitaire. And you see that the flow diverter is here and the wall of the artery is there. I made it stronger, you see the difference. So the solitaire is not really on the wall of the artery, I'm sorry, the flow diverter. And at 6 months follow-up, this is what we have. So the aneurysm is still open. And why is it still open? Not only, but the aneurysm is growing. There's a change, okay. This is another case similar to that, where they had put coils in a different institution, and again, it didn't work, it recanalized, and we placed the flow diverter, but you might see that the flow diverter is really short compared to the origin of the aneurysm, so it's again, try to stay longer, and over time, we had a 6 months control where again, same thing, we still have the aneurysm and the posterior communicating artery. So in both cases, the posterior communicating artery was keeping the aneurysm open by having flow around the flow diverter, because the flow diverter was not completely opposed well on the walls of the artery. This is where we are. And interestingly, this is my drawing, which shows where I thought things were going. So at the beginning, we put the flow diverter like this, but over time, flow went around the flow diverter to keep the posterior communicating open and the aneurysm open. So there is a solution to that, which is to go back into that channel and occlude the aneurysm and the channel with coils. You can see the channel which separates from the internal carotid artery. And so we put, this is what we found. We went through the channel with the catheter. We put coils, and occluded the aneurysm and the channel, as you see here. So it's a separate channel compared to the carotid artery. So this was our second case, which tells you that probably also in the first case, it was the same thing. So there is a channel which keeps the aneurysm open because there is a communicating artery which is requesting and calling the flow, and everything comes from the fact that the flow diverter is not well on the artery, on the walls of the artery. Another reason which makes the flow diverters not work is the presence of the communicating artery, as I've shown you yesterday, so I will go quickly through this. Sorry, because these are exactly the same images. I just want to go to the conclusions of this thinking. You remember, okay, so this is what we thought, that the presence of the communicating artery gives you flows which are counterbalancing one and the other. One goes in one direction, the other one goes in the other direction, and so the aneurysm is still continuously kept open by the fact that the thrombus cannot stabilize. It's always in continuous, it's living. And by being unstable, it will grow progressively. And this is another example of a kind of different, but always due to the presence of communicating arteries. So it's a basilar tip aneurysm. And we said, well, wonderful, we place the flow diverters like this. P1 to the basilar, and we will have a perfect result. 6 months follow-up doesn't really show a shrinking of the aneurysm. On the contrary, if you look at the posterior communicating artery, now the aneurysm is still there, very well filled. And you can see the difference between the two before at 6 months. And the big difference is the following. I hope I can show you. Okay. So this is a magnified image. More or less, we are in this situation. If I put a flow diverter like this, our desire is to have a result like this, meaning that the aneurysm disappear and all the arteries are kept open by the flow diverter. And the posterior communicating artery will keep the left posterior cerebral artery open, so the flow will go like this. This was what we wanted to happen. But in reality, what happened is that this flow in the posterior communicating artery would reverse into the aneurysm to keep the superior cerebellar arteries open. So this does not work. I go back to these images here to show you that here the superior cerebellar artery are visible from the basilar artery injection, and here they are visible when I inject the posterior communicating artery, the aneurysm, and the superior cerebellar arteries, like here. So the flow in the superior cerebellar artery comes now from the top of the basilar and the aneurysm. There's nothing you can do. You cannot occlude the aneurysm now because it's the route to the superior cerebellar arteries. Okay, so you can see that that was what we had, and the aneurysm is still there at 24 months. So it's a complete failure of our treatment. Some tips and tricks. What do we do? So in our procedure, in 90% of cases or more, we start with a short 6 French introducer in the femoral artery, and we place a good old envoy 6 French in the target artery. So very simple, one catheter, one guiding catheter, envoy 6 French. And usually we don't use any other catheters, no intermediate catheter. When you have a problem of stability, you may use an intermediate catheter, but more simple than that you can use a stiff wire as a body wire in the 6 French catheter. This is a wire we use, a 18 stiff steel wire, which has a platinum tip of about 5 centimeters, which is soft. And if you place it in a guiding catheter, it just makes it stable. Even if you have an arch with a big tortuosity, usually the catheter goes up and down and falls down. With this wire, it just stays there. So it stays, it doesn't take a lot of room, it's just 18. It's very helpful in stabilizing. You can put it whenever you need it, so you don't have to prepare it before. You don't use it, you don't open it. No need to exchange anything. And especially it's extremely cheap. You can find it on eBay for $50. So this is the wire. I don't know if you ever used it, but it's a very simple thing and very, very effective. In a case like this, where you see all the tortuosities here, but he had also tortuosities in the arch, as you can imagine. This is the wire inside the guiding catheter, which is a simple 6 French guiding catheter. And our microcatheter is going up. You see all the curves. Usually in these cases, you have to push a lot and pull. And we could even place a balloon because there was a stenosis here. And so even putting a balloon was not a problem. Always with the body wire in the guiding catheter, which keeps the catheter in place without any movement. So that's a cheap way to have you don't have to use an intermediate catheter. This was the result that you have already seen. So I won't go through this. So short 6 French introduction. The envoy 6 French, we usually put it as high as possible, almost in the skull. Then, of course, the 27 catheter. Any catheter is good. We usually use a synchro wire, but you can use any 14 wire. At the end of the procedure, we do a manual compression of the femoral artery, even if there is a dual antiplatelet therapy. We immediately wake up the patient. We do a CT scan in the next 2-3 hours. If you have an angiographer, a machine that makes the CT scan, you can do it on the machine. The quality is not the same. We prefer to do it on a real CT scanner. Also because we keep the patient with us on the room close to the angio room, so we can watch him, see how he is for 2-3 hours, then have a CT scan, which also makes it 2-3 hours of control. So all this keeps us more quiet. And then usually discharge it 2 days later. And the follow-up, we've been doing since the very beginning because we were very curious, a CTA at 1 month. It's not really needed. It just tells you how things are going. It tells you how the patient is doing. And it's usually the time when we stop one of the 2 antiplatelets. We don't use the Plavix, but anyway. So we keep only the aspirin. And we do it after the CT scan. So we call the patient, we see how he's doing, we do the CT scan, and we take 1 antiplatelet off. Then we do a DSA at 6 months. And usually we want to do an MR or a CTA at least 1 year later because we want to see the shrinking of the aneurysm. The aneurysm has to become smaller. That's the only thing that makes you sure that it's cured. If the aneurysm is not becoming smaller, something bad is going on. And of course, if the DSA makes you a visibility of the stent, if the aneurysm is still visible, then we want to repeat it 6 months, 1 year later. What do we do with antiplatelets? What we do is really something we are the only group in the world that's doing this, so don't copy it. But I tell you what we do. We use aspirin and ticlopidine. Both of them are very cheap. We start 4-7 days before the treatment. We do no testing. At 1 month, we stop ticlopidine. As I told you, usually is when we do the CTA follow-up. At 4 months, we stop the aspirin. So at 4 months, no drugs. So that when we do the 6 months follow-up with an angiogram, there will be no antiplatelets on board. This means that what we see is what there is. If the aneurysm is still open, we cannot say it's because there are antiplatelets. And so, we cannot do much about it. But it's a stronger information than if you still have antiplatelets, you have a weaker information of how the aneurysm is doing. So in 80–90% of cases, we follow this. Now I will tell you something more for the very beginners. Usually it's much better to go with the catheter more distal than needed. So go forward. You have bypassed the aneurysm, but still go a little bit longer. Why? Because when you push your flow diverters in the catheter, usually the catheter comes back. And if you are in this unstable position, you may lose the position of the catheter. So if you are very far away, it's better. Don't care. It's always easy to bring back the catheter. It's much more difficult to push it forward when you want it. Start deploying a little bit more distal the flow diverter, especially with some of these, the ones that shorten. Because if you start exactly where you want it, it will usually come back a little bit. And so it will not be in the right place. Start to deploy the flow diverter a little bit more distal than the exact position where you want it. Once you have deployed, you can always bring it back. To come back, it's easy. To go forward, it's much more difficult. Better to use a longer, better to use a longer stent than a shorter stent. Why? Because you want really to, I think I've talked about the fact that it's better to deploy a little bit more distal the flow diverter in order to be sure not to be too short. And you can always bring it back if needed. Why do we need a longer flow diverter rather than a short flow diverter? First of all, because there are always possible changes in the position of the flow diverter. So if you have just a very exact length, it might be that when it moves a little bit, it will not cover the neck. But the more important thing is that if you have a longer flow diverter, especially before the aneurysm, it will do a better job in making the flow of blood going through it rather than around it. So if you have a short flow diverter, some blood can go around and enter the aneurysm, but if you have a longer flow diverter, it will be much more difficult for flow to go around the flow diverter and go inside the aneurysm. So a longer tube makes a better flow inside it. Valves. Why do we need perfusion inside the catheter? Because if the flow diverter enters blood, there's contact between blood and the flow diverter inside the microcatheter before going out. There will be fibrin around the flow diverter, and when it goes out, it will not open correctly because the fibrin will keep it closed. So many people complain of the fact the flow diverters don't open, but most of the time it's due to the fact that there was no good perfusion inside the microcatheter. So you need these Y valves, or the more common one is the rotating. I think you know it. You just rotate the round thing here, and you can occlude or open, but it's a progressive thing. The more you, it's like a screw. The more you turn, the more it will close. The more you turn the other side, the more will open progressively. Is this good? With flow diverter, it's not very good. Why? Because if you open to make the catheter, the flow diverter go up and down, blood will come in, and this is we don't want. If you close, you have the blood will not come in, but you will have resistance on your wire, and you don't know if the resistance is due to the valve or to what is happening up there. So you open, but then blood will come in. So not good. It's better this kind of valve, which is on-off, and it's silicone. I don't know, you probably know it, but it's, so you just insert the flow diverter and you occlude it, and it can just be either occluded or open, not progressively. And when it's occluded, it will slide very well. There is no resistance. So it's much better. So what we do is to insert the flow diverter in the catheter, occlude it immediately, and then run water, as you know, especially to bring air out of the flow diverter, as we said yesterday or 2 days ago. And now there are also valves which are both. There is a part which is rotating, can fix this part here, but there is also a part which is on-off. So you can open it, and then with the on-off, you can insert your things. But if you want to keep in position, you don't want it to slide, you can always turn it. In case you need two catheters, when you do a jailing of the catheter for coiling, you can use these valves. And if you are like René Chapeau, who uses a lot of catheters, you can put something like this. So, and of course you can add more if you need, but then you need a very large guiding catheter. To balloon or not to balloon the flow diverter, we almost never balloon it, the flow diverters, angioplasty. Because if it's correctly deployed, you don't need any balloon. You don't need to dilate it. If you need to dilate it, it means that you have not done a good job in deploying the flow diverter. Unless, of course, there is a stenotic vessel. Sometimes it's due to stenosis. Sometimes in very large aneurysm, the aneurysm is pushing on the artery and you have a stenosis. But if the flow diverter wants to open only if it shortens. So if you place a balloon, dilate it, it will dilate. But then when you deflate the balloon, it will go back to the same because unless it has shortened, it will not dilate. That's why it's better to place it correctly rather than balloon it afterwards. Because if you balloon it afterwards, unless it will become shorter, which usually it doesn't, it will stay small, will not dilate. To coil or not to coil? We usually do in large more than 15 millimeters aneurysm. We don't know if it's needed, but we feel safer to do it. It all started with this case, one of our first cases. It looked a very horrible basilar artery aneurysm, very scary, and we decided to place the flow diverters, and we said, now we have a good solution for this case. We placed the flow diverters, we placed the pipeline. It was nicely put on the neck of the aneurysm. You can immediately see the difference of the flows. So we were very happy. We did a CT immediately after. You can see some contrast medium stagnating inside the aneurysm. 3 days later, she went home, and we did a new CT. Why? Because they were the first cases we did. We wanted to know what was happening. And you can see already a thrombosis inside the aneurysm, already at 3 days. We didn't know that this is not a good sign. 3 weeks later, hemorrhage. So this is the first case, and as I told you, one of the first cases in the world where we saw that the unruptured aneurysm could rupture after flow diversion. And since then, many other cases have been described. And the only solutions we can propose now is to, and this is the angiogram that was made at the time, is to put coils. And we have seen that by putting coils, we have decreased a lot the rate of hemorrhages due to ruptures of aneurysms after flow diverters. So some people don't like the coils. I agree. I would rather not place the coils, but there is a risk. And I'm not sure I want to risk a hemorrhage and then tell to myself how stupid you were, you should have put the coils. In case of giant aneurysm, one of the problems is to go distal to the aneurysm. As you know, to put a stent, any stent, I need to go forward. But here, it's very difficult to find a way to go out. So usually what you do is to turn around 1, 2, 3 times and then exit from the other side. But once you're there with your microcatheter, the catheter is turning inside the aneurysm. So there are techniques to bring it back and to have a, if you just pull it back like it is, everything will come back, but retain the curve inside the aneurysm. It will not become straight. So you have to make it, to do something different. The more simple thing you can do is to bring your wire back and pull on the catheter. So if there is no wire inside, the catheter is much more soft, and it will become straight in this position. So take away the wire and pull on the catheter very gently, and that curve will come straight. This is what happens. Another tip, if you are not satisfied, do not completely deploy. Why? Because if you deploy a flow diverter and it's not correctly deployed, it's a big problem. It will occlude the artery. So just don't do it. Take another one. And I know you should, especially at the beginning, talk to the distributor and tell them, if it works, I place it. If it doesn't work, you give me another one for free. Do it slowly, with careful attention at the correct opening of the device. Why slowly? Because you want really to open it well. It has to go to the walls of the artery. And so you look, while you do it, you look, and you look at it in different positions. So check frequently the ongoing deployment in many different projections. This is a stupid thing, but just to show you what we usually do. So you push on, deploy a little bit of flow diverter, then you push on the wire. By pushing on the wire, the catheter slides back. and you deploy some more flow diverter. At this point, you push the catheter so that the flow diverter will open because it's compressed, it's shortened. Then you deploy more of the device. When you come at a curve here, it will not open easily. So in order to open easily, you pull back a little bit the catheter, and the device will open. And then you push it back with the catheter in order to shorten it and to make it larger. This is especially true with the pipeline and with the silk. It's much less true with the Derivo, with the P64, and with the Fred, because they want to open more easily, so you don't have to do. The Fred sometimes every flow diverter has problems sometimes. We usually want to work under plane fluoroscopy in order to see very well the stent. We don't use the roadmap. So you look at the bone, and you see, I want it to open here compared to the anterior clinoid, posterior clinoid, whatever. So in this case, we look at the posterior clinoid and we say we want it start from there because this is where I want the flow diverter to start. This is an old pipeline, again, with but just to show you, we don't use roadmap. This is where I want it. Then I deploy it, and then I come down here. And then once it's deployed, I go back in the flow diverter. And here I retrieve the wire, and this is done. So it took some time, 20 minutes, half an hour, but it's correctly done, it's well done, it will work. During the deployment, I turn it around, I look at the other biplane thing, and if as you can see here, it's not very well on the, yes, I hope you can see it, it's not very well on the wall of the artery, not bad, not good. You need to push it, open it more, and then you are on the wall of the artery. After deployment, we often give a little push to the proximal end of the device to make it shorter and expand it better. I will show you how. And then we usually re-enter the device to massage it and have a better wall position. So this is what we do. At the end of the procedure, you have just deployed the stent. Here's your microcatheter. If you pull on the wire, the catheter, because of the tension, will go forward, and it usually goes there, and it pushes forward the flow diverter, and this, the more is short, the more is open. You want it short. Then we look very well at in all projections, and finally we wait some time, not always, just to check after a few minutes if there is any platelet aggregation. I don't know, do I have more time? Am I finished? No? Finished. No, I go on? I go on. You can stop me whenever you want. So, whenever you have to place a flow diverter, you have to look at many things. Size of the artery, size and shape of the aneurysm, size and shape of the neck, location, tortuosity of the artery, at the level of the aneurysm, before the aneurysm, after the aneurysm, all the branching vessels, all the perforators. If there are previous endovascular treatments, to coil or not to coil. So tortuosity of the artery is proximal to the aneurysm. If you need help, you can use long introducers, so 6 French, big catheters. We don't like them because they usually give dissections on the carotid artery. Long guide catheters, yes. Body wire, we love it. You need performing micro wires, so the wires you like it most, to go inside the aneurysm. Sometimes the 27 catheter will not go because it's too stiff, too big, so you need a smaller catheter and exchange for a larger catheter. In those cases, it's better to have a microcatheter which has a very big curve, like almost a U-shaped curve or a C-shaped catheter, in order to exit the aneurysm from the other side, as I showed you before. So in this case, in order to find the artery distal to the aneurysm, we had to go inside with a microcatheter, and with a microcatheter with a very big curve on the tip. If you have branching vessels and perforators, well, you try not to cover them. Especially, we try not to cover the anterior choroidal artery. Did we ever have a problem with the anterior choroidal artery? Never. So I don't know why I don't want to cover, but it's still, if we can avoid it, we try to avoid it. So don't cover branches if it's not needed. But if it's needed, it's usually not a problem. If you have a previous coiling, that is usually helpful because it's already half thrombosed, the aneurysm, and the risks are lower. But if, as I told you, if you have a previous stent, it's a warning because it's very difficult to know if you are inside the previous stent. When you try to catheterize a vessel where there is a stent inside, your wire will go in and out of the stent which is already there. And you don't know it. You don't know. You just don't know it. I don't know if yeah. So, but usually if you are, it's better to go with a U-shaped wire, and you can find a way and you think it's correct, maybe it's correct. So you follow with the balloon, you inflate the balloon. If the balloon inflates very well, it means that you are in a good channel. If the balloon has a waste, it means that probably you are not in the good channel and you're going in and out of the previous stent. So it's better not to do it. The good points and the bad points of flow diverter. Flow diverter, it's usually simple, fast, and easy, especially compared to the horrible aneurysm that you are treating. You're treating large, wide neck, thrombosed, fusiform, whatever aneurysms. And to do that, you have a very fast and simple procedure. It is a cure. Aneurysms shrink down, disappear, and don't come back. So that's the most important thing of flow diverters. It's a definitive, permanent cure. No more aneurysm, good vessel. Time works in favor of a cure, while with other treatments of aneurysm like intrasaccular, time works in favor of recanalization. The more you wait, the more aneurysm will recanalize with coils, web, whatever, contour. So for the patient, this is a completely different situation. In what will be my future? With flow diverters, you can tell them it's finished. You don't have to think anymore of your aneurysm. With other devices, you have to tell them, well, we will see a follow-up in 1 year, then a follow-up in 5 years, then a follow-up in 10 years, then a follow-up in 35,000 years. So it's something that for the patient, it's not correct for me. You should tell them, you're cured, don't think anymore of your aneurysm. And that's possible only with flow diverters. And as you've seen, okay, this is something that I've shown you in the tutorial, so I will not show it to you. Except this one, probably it was not in the tutorial. So this is the beauty. You have a large aneurysm, you put a flow diverter, and it's gone. And the pica, which was coming from the aneurysm, is still there. So it's an intelligent device. It occludes what's to be occluded, and it stays open what has to stay open. And this is, of course, the disappearance, complete disappearance of the aneurysm. We have already seen this. What are the bad points of flow diverters? The cost, of course. The need to learn new techniques. It's not a big, difficult thing to do. It takes time to reach the cure. This is more important because in certain societies, I do a treatment, a surgery, and you exit from the operating room that the problem is finished. With flow diverters, you have to tell the patient, I will put a flow diverter, and immediately it will be exactly as before, and it will stay there for weeks. Sometimes in the future, the aneurysm will disappear. When? We don't know. But so it's a little bit difficult, especially like in the US, where you should have a perfect treatment immediately. You have to prove it. There, they place more flow diverters, not just one, because they want to show that you have an immediate result. But the immediate result is not really important. The important thing is my future, my life. And as I've shown you, we have a low rate of success in basilar tip and posterior communicating aneurysm. There are new complications which are typical of flow diverters, and we already talked about that. The delayed aneurysm rupture of previously unruptured aneurysm. This is something that was not really seen with other techniques. This is the case. The delayed intraparenchymal hematoma, we have already talked about that. And I showed you this case already. So these complications were not seen with other devices. And everybody was frightened at the beginning, but now with the coils and with the very good washing of the flow diverter before using it, we have really brought this complication down almost to nothing. This is the real one. We have cases where the aneurysm keeps on growing over time, even if we have put flow diverters. And especially these are the originally giant thrombosed aneurysms, that even if you put flow diverters, they continue to grow. We think because there is feeding from the wall of the aneurysm. So you have arteries on the wall of the aneurysm, the vasa vasorum, and we think that this is something that keeps the aneurysm growing, and you cannot do anything about it for now. And the most important observation in the follow-up is the size of the aneurysm. If it's decreasing, the outcome is probably favorable, or certainly favorable, I would say. If it's increasing, I would start to worry. Thank you very much.